Okay, good evening, everybody. Thank you so much for coming, and welcome to the second public lecture here at Harris Manchester College for the conference, Conditions for Corrosion, How Are Good Healthcare Practitioners Made and Lost? So I'm Dr. Christina Lamb. I will be chairing the session tonight, and it is my privilege to introduce to you the speakers for this evening's program. We're going to be starting with Dr. Brian Brock, who is going to talk about what does listening to patients have to do with good medicine. And then he will be followed by a response from Dr. Farr Curlin. And I will introduce them both now, and they will present their papers, and then we will open up the floor to a Q&A, and I will help guide that portion of the evening. So Dr. Brock is Professor of Moral and Practical Theology at the University of Aberdeen. His work encompasses themes in theology related to disability, the use of the Bible in Christian ethics, and the ethics of technological development. Dr. Farr Curlin is a Josiah Trent Professor of Medical Humanities and the co-director of the Theology, Medicine, and Culture Initiative at Duke University. So without further ado, it is my pleasure to introduce to you Dr. Brian Brock.
Thanks so much. And I know half of us have been at the pub and half of us still wish we were at the pub. So I hope this is engaging enough to keep you happy that you took a break. The microscope and the telescope, along with the stethoscope and the MRI, have fundamentally changed us all. These tools for altering our perception have worked all too well. At first glance, they revealed the glories of the seemingly infinitely intricacies of the micro as well as the macro. So there's a sort of scaling of perception that is built into our way of being in the world that simply wasn't available 100 years ago. And because of that, wonderful and previously unknown worlds and structures are revealed at previously unimagined scales. Provoking entirely appropriate wonder at the complexity of God's creation. I added this slide at the last minute after having been in Hong Kong a couple of weeks ago, and when I went in, this is taken off the net, but when you come into the hotel, you see your face like that with a square around it with your temperature, right? So that we live in a world in which the scale of perception is constantly slipping away from all that the medical practitioner had access to for most of Western history. The problem arises when human beings begin to live at inhuman levels of perception and can no longer find their way back to the levels of the body at which the human person is given to us. Human relations take place at the level of the skins in which other humans face us. Our most powerful experiences of the world, as well as the daily joys of relationship, take place at this relatively untutored level of knowing other creatures. Though I'm not going to defend the claim in this short paper, it does seem to me that it's at the level of the skin at which Christ's claim through other creatures takes place. The question of the scale of our perception is ultimately a question about the image we have of the human, of the range of action we believe to have as human creatures, and of the ways we enact the range of action we believe open to us, that positions our stance in relation to our creaturely neighbors. And I think this is the Good Samaritan, obviously, and I often, if I was going to do a longer paper, I would discuss the fact that it's unlikely that the wounded man called out. So it was something about the way his body was appearing that was the call that the three religious men walked by. So I'm working out, and again, I'm not defending the claim, that a Christian ethic includes an ethic of creatureliness, which I think produces some resistance to the transformation of the face and the skin of the other into a static image or an image on the wrong scale. There are forms of habituation of our level of perception that can cause us to lose the habit of seeing what falls before our eyes. To be clothed with Christ, on my reading, means to be vulnerably open to others, to find ourselves open to what attending to the flesh of the other will ask of me. But there are different forms of seeing, as Jesus underlined in the story of the Good Samaritan. The vulnerability being invited by Jesus prompts human beings to become aware of the ways in which we have imbibed an optic of distance observation, perhaps the distance looking down of the satellite view or the trend following of vital signs on the screen. None of this is particular to medical professionals. Lots of us look on the world as something to be recorded for representation on a social media feed, or watching what others put online as a sort of reality TV show, or even the picture of one's face coming into the hotel. Is that supposed to tell me this is a safe hotel because nobody can get in here who's infected with COVID? Or is it kind of subtly telling me you're going to have to pay if you come in here and infect other people, right? So the level of our interaction is often keyed to the level to which we're attending. We can become habituated to not see what's before us because we're simply looking at the wrong scales, ethically speaking. The doctor can learn to read a machine that shows vital signs and not hear what the patient is saying. The pastor can read social cues in the clothing of a parishioner and be calculating social value. The professor can see the polish of a student or a colleague, treating their markers of social status as all that there is to see. To be conformed to Christ entails that being made ever more sensitive to what is outside of us, being uncovered, we become extrinsically oriented. Is not this to become naked before the world? Part 2, the working surface of the human. To live with people is to live with animated skins. And I'm going to talk a little bit about my son Adam, who doesn't speak, or more precisely, speaks very little with his mouth, a bit with his hands, and much more in his bodily movement. And some of what he says in these ways, some people find uncomfortable. For instance, what most of us do by shaking hands or various sorts of those kind of physical greetings, he does by putting his hand on your mouth. We could have a long discussion about why that's the thing he does, but that is the thing that he does. And he has taken to, for instance, saying "I love you" by patting his chest. It's a refutation of Wittgenstein's claim that there's no such thing as a private language. So he communicates only at the level of the skin. And so too does his medical history communicate itself. That's why I moved this down, because I wanted you to be able to see that this is his 8-year-old experience of having heart repair and the drains that go with that. This is his actually that was 6 months old, sorry. This is his 8-year-old scar from pulling down boiling water in the kitchen. And these are 2 portacath scars, along with the long line vent from chemo treatment when he had leukemia when he was 8 years old. And you can't really see the chicken pox marks, but we have a great picture of him looking like a spotted Dalmatian. The portacath is a remarkable invention, which caused me quite a bit of meditation when he had one. It's a half sphere of metal under the skin, and that's it out and that's it in. So those scars on his chest were from when you have leukemia. Skin doesn't heal very well, so he had it in, and he needed that because a long line hangs out here, and that was not really good for him. It was catching on stuff, and he didn't understand what it was. And so the portacath has a funny little needle that can go into this bump, put through that rubber hole, because you can't put chemo into peripheral veins because it destroys peripheral veins. And I think this is, again, a really sort of fascinating worked example of what we do around the skin, how the skin is the layer between us and the world, and the difficulties of living together with people when you need to access to their skin to get blood out, for instance, or to put something in this case, to treat him. Yet the whole process of going down in treatment begins when people who understand the way Adam lives in his skin notice that something is awry in the mysterious zone of his inner body that he can't speak about, but he can display, like the man laying in the ditch in the parable of the Good Samaritan. We took Adam to the hospital to begin the test that discovered the cancer in his bone marrow because of the way he inhabited his skin. Medicine may possess the tools to look beneath the skin, but it forgets to its peril what it means that the primary field we engage when we converse with other creatures is their outer surface. We live as beings encased in skin, and we relate to others as skins. All our senses and orifices are folds of the skin. The rest of us supports this communicative surface. We, the I, can only be interacted with, seen, heard at the level of the skin. And this has a lot of implications ethically, which I will quickly summarize. It's the condition of the ethics of consent. The bodies that end at the skin allow the moral claim that says, my body, my no. Obscenity laws zone and partition the skin, what counts as something that's illegal to show of the skin or not, as does fashion. Erogenous and obscenity zones are what are being manipulated in law and fashion. And one of the many paradoxes of our time that gather at the level of our skins is that in many countries today, it's legal to look at the body's, look on bodies stripped of skin. This is Von Hagen's Body World exhibition, which has been seen by millions of people here in a sex act. And then, sort of free the nipple protesters in one of the museums in Paris, because it's illegal to go dressed like that into a public space, but people can visit the stripped bodies legally. So one of the many oddities of our time is that we can look at bodies stripped of skin, but we can't look at the skin of certain people in certain contexts. At the same time, the beautifully healthy bodies that drive consumer marketing draw on the vitality and liveliness of the bodily form to attract our attention, to the form and texture of the skin. The barrage of perfectly toned bodies and blemish-free skin that saturates our popular culture often provokes in us internal sense of deficiency or lack. And this is just a sidebar. I think it's probably safe to say that if Adam and Eve covered their pudenda, the traditional term, their genitals, our shame at our body is now sort of body turgor, tinner, blobbiness, right? Like people don't mind being naked, but they don't want to have orange peel fat. So we are beings who are dissatisfied in our skins and with our skins, and who are flooded by images that promise us what we lack in highly stylized ways. The modern age has experienced a fundamental change in how it understands the human skin to mediate between the self and the world. In the first instance, because of our alteration of our sensory relation to the world through instrumentation. But before the rise of modern instruments for altered seeing, the Western world was already made up of an unstable mixture of sensibilities about how the self appears in the world, derived from its Hebrew and Greek influences. The Hebrew tradition focuses on the importance of veiling persons, divine and human, and the Greek on authenticity as stripping away veils. For now, it's going to have to be sufficient, we might come back to it, to recall that in the Old Testament, God is presented as clothed in glory as in a garment, Psalm 104, among many other places, who no one can see directly and live. When Moses comes down from Sinai after seeing God from behind only, he has to be veiled in order to protect people from the transferred holiness shining out of his face. In Israel, nudity is seen as a sign of loss or deprivation, the state of the slave, the poor, the mad, something to be remedied as an injustice. There is thus only a superficial resemblance between the biblical language of veiling and Plato's occasionally descriptions of virtue as veiling the human form. Many patristic theologians incorporated versions of the Platonic understanding of the body by way of the metaphor of the body as house. And I wanted a better picture than this, but we're going to have a Halloween picture of a a body is house, but we have inherited, I'm arguing, a Platonized picture of the body in which the self is inside the body and looks out through the eyes, which can be opened and closed. Cued by a few biblical passages, the scriptural logics are refocused by patristic writers like Augustine on Greek vision-oriented images of the body. And this vision-oriented picture of the body, of the eternal self or soul, is envisioned as looking out. The body house picture of the human subject is static but capable of modification by the self inside. The imagination of the role of sensation is key here, in being imagined in terms of the functioning of the eyes, which are capable of being opened and closed at will, unlike the other senses. In this picture, the skin is fundamentally impermeable and therefore needing apertures, and this impermeability sets up a discrepancy between inside and outside, which emphasizes the importance of, and also the difficulties of, the self establishing contact with the outer world. You'll see that you'll sort of recognize this as a condensed critique of modern kind of Cartesian pictures of the self. This imagination of the body was to crystallize into what became the canonical image of the body in modernity through the rationalization and objectification that occurred in the Enlightenment. What's important for our purposes is how this image of the body departs from the Hebrew emphasis. In the Hebrew Bible, the self and fleshy body are fully coterminous and fully contingent. There is no eternal soul self inside the body. The self is a body. This body self is related to the world through physical contact, not looking out at the world, but immersed in it. It's better here to think of the key sense as touch or hearing, neither of which can be closed off from the world at will. This non-dichotomist epistemology implies that creatures were not outside of, but always complexly interweave with the creaturely world, from the microbes in their gut to the viruses that form their genes. The human is not above or distinctive from other creatures as a creature. Part 4, medicine as going behind the skin. What's often called Hippocratic medicine, before the 18th century in the West, understood the task of medical diagnosis to be a matter of listening to nature. Bodies, it was assumed, were capable of healing themselves. So there's the humor's story of what's going on inside the body. There's imbalances in the humors, which is where things like bleeding, leaching, the skin was seen at, basically most of the treatments were letting the wrong humors out so that the body can recorrect itself. And so the main tool was skin abrasion, skin incision. And how that was done, practically speaking, was through speaking, counsel, sympathy, to reinforce nature performing its own work of healing. And the kind of techniques that were used from our perspective were probably less helpful than helpful. Poisons or powders, that to us really don't look like they're helping much. This view continued to dominate the West until the 18th century. And in this model, the body was understood as in constant flux, driven by different humors and venting itself as necessary through orifices in the skin. And this is why we had these sort of venting treatments, and also why people weren't concerned about infection, because they didn't see the inside-outside boundary as working that way. Nothing comes in from outside. It's only imbalances inside that are the problem. What happened in the 18th century was precisely the rise of tools which reshaped the doctor's sensory relation to the body. Medicine was reconceived as a practice of using tools to listen more closely to aspects of the body, such as the heartbeat, though counting heartbeats only arose in the 19th century, and of using tools to intervene like forceps. A doctor is defined as someone who deploys tools to fix organ systems that the expert knows how to diagnose, but the patient doesn't. The doctor's expertise is now deploying diagnostic tools, special apparatus. And here we have to understand the later development of these tools into the whole armory of mechanical and chemical means of testing the body to be just a further trajectory down this route. The doctor became an expert using specialized tools to intervene in the functioning of bodily parts or systems, whether chemically, through drugs, or surgically. The tool-using model of medicine now is in the midst of its third turn, and this is just Illich, the turn to the body as system. Here the body is conceived as an extraordinarily complex arrangement of feedback loops that are homeostatic in nature. They're trying to balance themselves out. And the body is basically an informational balancer, reorganizer. Machines that can visualize changes in biological functions over time become necessary to make the feedback loops and information flows of the body visible to both the patient and the doctor. Now a healthy body is only truly and accurately knowable through the tools of testing and the conceptuality of probability, right? And that's why we need face temperature measuring in hotels, because we don't know if we're sick, but the computer can tell us if we're sick because it looks on us in a way that we can't even feel. This body is by definition not susceptible to meaningful narration by the patient, who may experience some symptoms but not be able to connect them to bodily malfunctions. And this is a very common trope in descriptions of how the doctor-patient relationship goes, that the doctor is the one who can tell you what's going on when you feel a lump in your throat or any given pain. Like you can't possibly know what that is, but all you can say is the symptom. This probabilistic account of health yielded the contemporary assumption that the patient's account of their own sense of malady is really only a prompt for deploying tests which will find patterns that underlie the patient's perception of their body. Thus does the doctor, as a systems analyst, arrive at the opposite pole to the Hippocratic doctor, who would engage the body much like a good theater audience at a tragedy. The Hippocratic doctor listened to the complaint of the patient to perceive the singularity of this distinct patient with his or her uniquely configured palette of physical sensations and mental narratives about the sequence of those sensations in order to locate the sort of imbalance in the humors. Such engaged attempts to narrate the body of the patient have been displaced by what's often becomes a tragicomedy in modern medical practice, in which patients and doctors alike are both far too comfortable using yes, no, question, and answer modes of locating symptoms to generate a diagnosis. Today, patients and doctors alike often have internalized views of the body as seen through medical tests and visualization techniques. Both understand themselves in ways that have been decisively configured by the contemporary frameworks of knowledge. And a typical example of this is the self-objectification of a sort of breast exam or a testicular cancer exam, right? You kind of take a distanced view of your own body in service of the distanced view that will treat your body. If the experience of one's own body was in fact irrelevant for diagnosis and treatment, we would expect those who are unable to articulate their experience of their own bodies to be the perfect patients of modern medicine, like Adam. That they are not the perfect patients exposes the reality that the modern diagnostic emphasis on the functioning of bodily systems and organs is in fact always precariously suspended above and reliant on the safety net of the earlier modes of diagnostic listening. Though modern physician training has in effect de-skilled practitioners in the practical arts of listening to patient stories and attending closely to whole bodies, the attempt to live by testing alone is so fraught with complications that these older and more time-consuming forms of listening remain indispensable in healthcare of real quality. Moving very quickly, their medical training would suggest has sort of displaced the master practitioner at the bedside by the lab bench scientist. So the older apprenticeship models at the bedside have been demoted within the curriculum against the kind of high-powered research doctor. And so the skill set of the master clinician, which isn't susceptible to scientific substantiation, leads to the devaluation of the sort of speaking and listening, active, collaborative work of the master clinician. So it's not modeled often for medical students, nor is it often treated as an essential aspect of good diagnostic procedure, along the lines of the superfluous role of ethical training. The shifting of pedagogical practice toward testing is grounded in the evolution of medical knowledge, is the claim I'm making. And I've sketched this history of the reshaping of medical examination to show how listening to the patient's account of their bodies changes over time from the skilled practice of the tools of listening to listening, from listening to deploying tools to listen to body parts or systems. A particular illusion can now arise, the belief that medical tests can mechanically determine correct treatments. And the result is a misplaced diagnostic certainty. Comprehensiveness in medical testing can't yield diagnostic certainty, as if the sum of all known tests would yield an unambiguous diagnosis. Modern medical tests calibrate to normal ranges of functioning in a population. And so the fact that somebody's body is not within normal parameters doesn't necessarily prove that they're ill or not. And it certainly doesn't make a normative claim about how bodies should be. So there's a kind of gap between statistically normal ranges of functioning and how they relate to any one individual body. Nor do anomalous value ranges automatically indicate any linkage to a presenting complaint. The regularly lamented proliferation of tests is one hint at the impossibility of generating diagnostic certainty by tests alone. And I've been influenced in this argument, I won't read this whole quote, by Harvard Medical School emergency medic teachers Leanna Wynn and Joshua Kosowski, When Doctors Don't Listen, How to Avoid Misdiagnosis and Unnecessary Tests. And they're basically saying there's a lot of thresholds in diagnostic judgment, and it's not an algorithmic sausage machine, and it shouldn't be treated as such. And it's dangerous to be treated as such. In short, medical tests may well reveal abnormal values, but this may be unrelated to or not the source of the presenting complaint. And close attention to the specific contours of the presenting complaint may suggest the relevance of tests that routine testing protocols are not going to pick up. So in the final analysis, modern diagnostic testing can never achieve certainty without recovering older practices of close listening to patient histories. And I'm sort of suggesting that what we need for recovery is the open, collaborative listening, a discovering together, right? So when Adam goes to the doctor, he brings something to the table, his parents bring something to the table, his doctors bring something to the table, and nobody knows yet what's going on until that collaborative work's happening. And that collaborative work is also necessary for the treatment to function. So there's a partnership that needs to happen, and the symptom needs to not displace patient narratives. Working hypotheses are in fact the ground of any diagnostic certainty because they should guide the ordering of medical tests. And when I say working hypotheses, I'm pointing to the problem that of the claim to expertise that sometimes quells this discussion when a medical professional presents themselves as an authority who can't be queried. And one of the things Wynn and Kowalski are really good on is they have a whole list of ways of questions you can ask to help your doctor not shut down a collaborative conversation. Like, okay, if I have X that you say that I have, what happens next? And getting them to say what happens next. So if it doesn't develop the way they think it will, then you, at the next step, have a more open conversation about how that might proceed better. Some doctors may medicine by test. and the proposal that doctor-patient relationships require much higher levels of communication and openness, a seductive fantasy since, and I'm quoting one of those, most acutely ill people just want the experienced person to take over and do what has to be done and do it fast. It's certainly more psychologically complex for a doctor to approach a patient holding the mantle of expert lightly. For medical professionals to admit up front that their diagnoses are hypotheses shakes the carefully constructed of inviolable medical expertise. And I'm speaking about what was called on Tuesday one's professional identity. I'm not saying doctors shouldn't know things and they shouldn't know them well. I'm saying how do they present themselves as the bearer of that knowledge. We've had conversations already. Like somebody who tells you that they're a good athlete or a good cabinet maker is pretty much guaranteed not to be one, right? So there are stances that you can take to tell people that you have authority. And I'm an expert is, I would argue, a classic one that happens in a medical context to shut down the real back and forth necessary for good medicine to happen. In the final analysis, there are no substantial moral reasons for healthcare providers to resist presenting themselves. There are substantial reasons for healthcare providers to resist presenting themselves in the social role of the scientific expert. When medical professionals assert the inviolability of expertise, they set up barriers to the honest communication that's crucial to good healthcare, itself a significant contributor to litigation against doctors when things end up going wrong. The history I've recounted suggests why such close listening to particular patients not only goes against the grain of the practical processes in modern medical systems, but even against the internalized self-understanding of most doctors and patients. Viewed in historical perspective, modern Western medicine is pretty aggressive in its approach to treatment. And in this world, disability and dying are treated as enemies, not as parts of life. And as a result, the roles and the virtues of multifaceted listening to the body and non-intervention seem to have been lost from view in modern Western medicine, by and large. Here, the phenomenon of disability, I would suggest, presents an invitation to practitioners of modern medicine. Without surveying the string of studies that have substantiated the point, I think it's safe to say that modern systems of healthcare find it very difficult to provide high-quality healthcare to people with intellectual disabilities. The CPOL report, I encourage you to look up. It's one of about 10 reports over about 15 years. And this is a classic. They all sort of make comments along this lines. When compared with people without intellectual disabilities, contributory factors to premature death, and you'll see that there are substantial differences in mortality rates, include problems in advancing care planning, adherence to the Mental Capacity Act, living in inappropriate accommodation, adjustments of care as needs changed, and carers not feeling listened to. This reality exposes a problem at the heart of modern medicine. When attentive, multifactorial listening is devalued in clinical care, it becomes impossible to respond well to non-standard cases. Thinking hard about disability, especially the difficulties of those with learning difficulties in accessing healthcare, might help those seeking to live thoughtfully and faithfully within the institutions of modern medicine to think afresh about their practices and the premises on which they rest. Medicine isn't a static entity. Increases in therapeutic and diagnostic humility could well yield not only a more humane, but perhaps an even more effective practice of medicine. If we're to even begin to face the hidden brutalities of our modern humane medical institutions that they're inadvertently inflicting, it'll be critical to re-examine the ways in which medical knowledge imagines what it takes to be the normal human body and mind, and what it takes for bodies to be part of the medical system. This is scanning up to the rest of Adam, or at least the part. I was working on this paper during the heat wave in Aberdeen last night, and I was like, I'm just not going to describe this, I'll just take a picture. So this is a week old, this picture. Here, medical professionals gentled by engaging learning challenged patients might well be the promise of a gentler medicine overall. Thank you.
Thank you, Brian. I want to focus on, or take off from a point that Brian makes that seems to me clearly true, when he said, "It is safe to say that modern systems of healthcare find it very difficult to provide high-quality care to people with intellectual disabilities." Why is that? And Brian locates the problem in part in listening, or the devaluation of listening. When listening is devalued in clinical care, he writes, it becomes impossible to respond well to non-standard cases. I'm going to come back to that in a moment, but as I was thinking through Brian's paper, it seemed to me that that maybe paradoxically something that seems almost the opposite may also be true, and that is that when clinicians defer too much to what the patient says, it becomes impossible to respond well, to learn how to respond well to those who cannot themselves say what is going on, which would fit someone with a serious intellectual disability. Brian writes, in the Hebrew Bible, the self and fleshly body are fully coterminous and fully contingent. There's no eternal soul self inside the body. The self is a body. This body self is related to the world through physical contact, not looking out at the world, but immersed in it. And if this is true, and I take it to be so, then why should medical practitioners listen to patients rather than, or why should the emphasis be on listening to patients rather than on studying the body and its movements? After all, sometimes patients make mistakes in the stories they tell. Indeed, it seems to me that much of the over-testing that you rightly point out is due to taking patients' stories maybe too seriously, taking them to have an authority that is that they don't actually have. Because of the cultural dynamics you describe, patients also have learned to see themselves as, the spirit inside the machine. And therefore, when they have experiences in their body, they very frequently come already with working hypotheses themselves that are put into the terms of the machine and its breakdown and what they see going on. So they see through a microscope themselves as sort of the machines, or they see through the telescope, see themselves as fitting into a spectrum of risk factors that give them anxiety that they then imagine you need to do a test and tweak things to adjust. So why does a good physician listen to patients? Seems to me partly out of moral regard and respect. That's how we show as humans respect for one another, is to look each other in the eye and listen. But also because generally patients have a privileged position from which to say what has happened and is happening to the body, to themselves. The patient's story helps the clinician settle on a story that the clinician takes to be true. Or as Brian notes, at least helps the clinician form a hypothesis that gives them a ground for, in a more parsimonious way, doing whatever further evaluation might help to clarify what's going on. In this dialogue between patient and clinician, both are seeking to understand the truth about this fleshly body, the truth about what has in fact gone wrong, what can in fact help to put it right. And the key point I'm trying to make here, I'm belaboring it here, but I'm trying to make is that medical practitioners listen because the patient's story is often, not always, but often the best provisional proxy for the true story regarding what is going on. And importantly here, the true story regarding what is going on, that is the practitioner of medicine's business. But the story does not establish what is the physician's business, nor necessarily what is going on. And so let me go back to the problem of medical practitioners not caring well for patients with intellectual disabilities. It seems to me true that physicians move too quickly to the microscope and the telescope, so ordering tests, the normal ranges of which are poor proxies, as Brian pointed out, for the patient's health. They're poor proxies for anyone's health, but they're especially poor proxies for the health of those with conditions that lead to disabilities. But Clinicians also, it seems to me, defer too much in our time to patients to say what is wrong with them and what it is that the medical practitioner should do for them. It's kind of a feature of the way the whole modernity also emphasizes the autonomous self, being able to enact their own story authentically and find help from others to, where necessary, to bring about the sort of fruition of that story. But practically, very often, patients have a story, and that physicians are taking that as telling them what they need to do next. So insofar as I'm right about that, then part of the antidote to the problem that Brian is describing is for physicians to reclaim their proper authority of expertise. I'm proposing that. Not by acting as if their expertise is inviolable, but by affirming that, having heard thousands of stories and observed thousands of bodies, the clinician has learned something about which stories make the most sense for particular patients and which do not. It's not to say that they can't make a mistake, but they have some proper expertise. And I think it's interesting here, we talked about this yesterday, that patients with intellectual disabilities don't present with something that is very, very common, makes up probably 1/3 to 40% of all presentations in primary care, which is medically unexplained syndromes, right? They don't come in with syndromes that come to be called fibromyalgia or chronic fatigue. I'm trying not to get myself in too much hot water here, but things like long COVID, chronic Lyme disease, all kinds of syndromes that they're things that are bothering them that people can't explain in terms of the machine breaking down, and explain in terms of the models physicians have. Patients with intellectual disabilities don't do that. And seeing that leads me to, I think, see the problem with practitioners prematurely taking the posture of expertise, especially when caring for patients with intellectual disabilities. So when patients with serious intellectual disabilities present to medical practitioners, it's not because they have something to say to the practitioner, generally, much less because they have a theory themselves regarding what is wrong, that they need the physician to test for them. But that is very common among patients who don't have intellectual disabilities. But what happens is that the reason they come in is because the patient's caregivers have observed, have seen in the skin, this fleshly body, they have observed something wrong with the working of this body, this self. And in that sense, it seems to me Brian is right to be skeptical of the physicians taking the posture of being the expert, because to develop expertise regarding the well-working of the body, the health of someone with an intellectual disability, so that you might, for example, pick up before it's too late that something has gone wrong and needs attention, that requires a close patient attention over time, which attention gives the kind of knowledge or expertise that only really caregivers will have. And so it seems to me the good clinician will ask the caregiver to speak from their expertise, their proper expertise, by asking them, what have you seen? What has been happening that you notice is a sign that the patient's health is not right, it's breaking down. And then, so in this sense, the clinician reasonably takes what the caregiver says more seriously than he takes the average patient's story about what's going on, or their theory about what's going on. I hope that makes sense. So I'm going to end here where Brian begins in his paper. He notes that we characteristically today seem to mistake our range of action with respect to ourselves and our neighbors. So what is the medical practitioner's range of action? It seems to me it is the patient that they attend, or the patients that they attend, but they attend them one by one. It's not the population. It's not the enzyme or anything smaller than the patient. Brian commented about the demise of the master clinician. I've observed that demise in my own brief career in medicine. I think of Jim Bryan, Axel O'Hoole, Hank Lassane, Tom Miller. These were 4 master clinicians that when I saw them in action, did what psychologists describe as sort of that moral elevation, or a kind of inspiration and excitement in watching the way they worked. None of them discovered things, to my knowledge, with microscopes. None made a difference through scalable programs. They were just really good at attending to fleshly bodies, one at a time, listening, observing, touching, looking in the eyes, and then doing focus tests, helping patients figure out what was going wrong and what can help put it right for this patient, given this patient's vocation. And these guys were all characterized by joy, which I think connects us back to the problem of corrosion that we're wrestling with here. So one medical education strategy is just to apprentice novices, like I was, to master clinicians like they were. Just say, follow them around and do what they do. By contrast, medical education today is much more characterized by encouraging students to mistake their range of action, either through encouraging them to make a difference by going through the microscope, right, doing research that can be applied to lots of people, or by taking up the telescope and drawing back and trying to change populations through advocacy or public health ventures. And it seems to me both of these are ways of detaching from individual bodies. They both involve often a kind of impatience to make things happen. In that impatience, patients, it gets confusing there, patients become almost an obstacle to get past in order to get on with making a difference in the world. And that seems to me to show up really strikingly. The more a person won't get better, or like someone with an intellectual disability, requires you to slow down and really pay attention and spend a lot of time to help this one person, the more this shows up, this problem. The repair to this corrosion is to recognize, I think, practitioners' proper range of action, caring for the fleshly bodies of individual patients, and to rediscover that this is really good. It's really good. Enough to fund a lifetime of joyful practice. I'll stop there. Thank you.
Okay, well, thank you so much to Brian and to Farr for helping us pay attention to the need to see the people and not just the bodies in front of us as healthcare professionals. So now we have about 10 minutes for questions. If you'd like to raise your hands, I'll bring this microphone to you, and then you can feel free to ask Brian or Farr questions at this time.
Thank you so much. During COVID, bizarrely, well, because I was sitting down all the time on my little computer, I got DVT, and I had to go to the doctor 4 times, and that was because the second time I got a false negative, a test which gives lots of false positives, but not very many false negatives at all. I was a false negative, and so I had to keep going back. I think in the end, 4 weeks before I had an ultrasound, and then they said, yeah, that's DVT. So I want to raise the question about the reliance on tests. So you put up the reliance on tests in terms of the normal range and the abnormal range, but there's the opposites too. That a test that's reliable 98% of the time means 1 in 50 times you miss it. And so even though you should be able to see the things on the skin, in my case, still it's this sort of reliance on tests, and the numbers came in, and then so I just wanted to ask about the over reliance on tests as a kind of de-skilling.
I mean, Farr is obviously going to be the one to answer that. I think Wynn and Kowalski, I learned a lot from that book. It's worth reading, I think. Let me sort of tell you some of the levels at which I'm thinking about these issues. I could tell you a lot of stories, but the deep vein thrombosis reminds me, part of the reason we went to the ports was that Adam did have a long line. And one day in 6 weeks, both my wife and I couldn't be there with him, and we said, somebody needs to be with him. And he pulled it out and got a deep vein thrombosis from that, and we had to give him heparin shots for 6 months daily. As Farr was talking, I was thinking, I wrote a chapter in my book, Wondrously Wounded, called Notes on the Healthiest Guy I Know. And it was really illuminating your description of the alternative problem. I think that's a really useful diptych, because Adam doesn't see himself as sick. He never sees himself as sick. He never comes in saying, I want a diagnosis. He doesn't know what a diagnosis is. He doesn't care about a diagnosis. He has pain. And somebody else narrates that pain by looking at cues about the way he lives in his body. And he has to do that in a place where you can't really count on other people. He doesn't know, why am I in this building? Why am I sitting on this chair? Why can't I go out and do something else, right? Like, to him, being in the hospital is just that's a low quality of life moment. And I tell the kind of deep vein thrombosis story just to give a little concreteness to the way that the kind of practicalities of listening to the needs of someone with special needs in their navigating this Byzantine thing that they don't understand. It doesn't work well in the way the structure of the institution is put together, and it can generate actual anomalies, iatrogenic outcomes. But yes, I totally agree that sort of false positives are built into diagnosis by testing.
And false negatives. I mean, this is part of living in with limited tools, you're going to have some false negatives. It's interesting that I remember being taught the clinical reasoning specifically about DVT, which is that if you have a particular story that makes sense of a DVT, and you have findings on the physical exam that look like a DVT, namely unilateral swelling of the lower leg, then you have a pretest probability high enough, arguably, to treat without a test, or to do a test that's very sensitive, so that you're not so much worried about being specific because you already have a pretest, you already have a high likelihood that going into the test that's what it is. And I think we lose even that level of thinking because we're just so accustomed to doing whatever the gold standard test is, which may not be the right test for someone who you already are pretty sure has what you're looking for.
I think too, though, the master clinician that Farr's highlighting is one who's governed by prudence, because stories can mislead us as well. And so for the clinicians in the room, if I told you a patient came in with fever, pain at the umbilicus, which migrated to the right lower quadrant, you'd tell me it's appendicitis. But we know now with the CT scan that even patients with those classic story symptomatology, there'll be a 20% false negative, right? Their appendix is normal. They've got pain for some other reason. Maybe it's strep throat. And so with my trainees, I also have to pause the brakes, right? And sometimes the technology corrects us and helps guide our interpretation of the stories. Other times, when caring for patients with intellectual disabilities or newborns, there aren't those technologies available to us. And so it is the skin, the appreciation of the change of color, how taut the abdomen is, how it feels, picking up all these cues. But I think what both of those are governed, whether the over-reliance of tests or the needs for tests, or when tests just aren't available, ultimately is this prudence, right? This master clinician, because they've been there before, they've been burned before, normal appendix, I'm not going to forget that again. We probably should get a scan before we go to the operating room, those sorts of things. So I think it requires, as Farr said, hundreds, thousands of cases where you begin to learn so that you can partner with the patient and the families to help interpret those stories or interpret the technology.
Those are all great points. As you're talking, it reminds me, part of the reason I'm making the case that I'm making is a scale problem. And the scale problem was alluded to about don't treat the enzymes, don't treat the population. There is many less people like Adam in the world, which means nobody's going to get the practice developing that kind of skill on them. And of course, there's no investment in, I mean, it could be that their mental delay has to do with kind of receptors, neurological receptors, which are not cleared because it's on that gene. But we don't know because no money is spent on testing that because they're statistically irrelevant. The being on the wrong scale, we have a macro picture of treating populations and medical costs, and therefore we have subtle levers to make sure fewer of costly people like Adam exist in the world. We do that with a lot of sort of subtle language games. And when fewer people like him exist, then our system becomes less and less able to actually handle them.
I know I'm standing between us and PIMS, so I'll make it very direct. And in part, this is a bit off topic, but I was imagining the analogies between the arguments about expertise in bioethics and ethics more generally. And there's a kind of real, some who really strongly argue for moral expertise. Ethicists have training. Ethicists know the telescope with all the theory. But I wondered where you stand on kind of expertise of an ethicist in these debates. Do you want to encourage a kind of similar approach of dethroning and listening? I mean, I talked to an effective altruist who says, I don't listen to people in the developing world because they don't know what they need. So there is a kind of familiar arguments about paternalism. Okay, but there is a decentering of the professional expertise. And obviously in the United States, we have a massive debate about distrust of experts in medicine and maybe even ethicists. All they're good for is grading papers. So can you give a defense of the bioethicist?
I think the backlash is warranted because anytime somebody stands up and says, I'm an expert, the proof is always in the pudding. And I don't think our guild, especially the ones who would stand up and say, I'm an expert in a theory set, that means let's sit down and have a survey of all the different methods. That's a skill set which helps no one. That's why, to me, an ethicist should be able to talk about something like diagnosis and have an actual practitioner say, yeah, that's a real problem and a problem that I hadn't really quite captured. If I can't do that, I'm not doing my job. That's how I see ethics. And for me to just stand up and say, I'm going to pronounce on what counts as, let's say, the term conscientious objection and what doesn't count as that, that's a kind of stance that I don't think actually helps people.
Thank you so much. Well, thank you everybody for those wonderful questions and these wonderful talks. So we're at the end of our session. I think Julie will close us with comments. Thank you.